This is a gentleman, is a middle-aged gentleman, diabetic, smoker, and he came to us with recurrent TIA and also an acute, sort of a chronic stable angina. We did his angiogram and we found that he had a LAD and a diagonal stenosis which was quite tight, and he had a bilateral carotid artery stenosis. On the left side he had almost like a 90 to 95% stenosis. This is a duplex scan, and then so this is on the, once you put a color, that we see how tight is the stenosis on the left side, and this is on the right side. So now we had a challenge. So here this is the angiogram which shows that there was a stenosis in the ostium of the internal carotid artery on the left side, and both the vertebrals were normal, and they were codominant. This is the innominate angiogram on the right side. The renals were normal. Can somebody help me on this? Yeah. So this is an angiogram of the right internal carotid artery which shows a 90 to 95% or maybe more at very tight stenosis. There was an evidence of a thrombus, suspicion of a thrombus in this region, and we weren't sure how to tackle this lesion. Obviously the filter was not a choice because there was hardly any space to get the filter across this stenosis. So what we thought was we'll probably go for a proximal protection. But we also had a concern because the contralateral carotid artery was, internal carotid also had a 90% stenosis. But on an angiogram, we thought about it and then thought maybe let's try a MOMA device. Maybe the patient is going to tolerate because the vertebrals were good. So we tackled the right carotid first. We passed in a guide wire. And then we got a MOMA device. This is a 7 French MOMA device. And we just parked. Once we had the device in place, we had a external carotid balloon inflation, common carotid balloon inflation. Then after that, we proceeded in a similar way. We did an angiogram. You can see how tight is this stenosis. Clearly not suitable for distal protection. We had some difficulty in passing a guide wire, 0.14-inch guide wire across the stenosis. We chose a hydrophilic whisper wire to actually cross the lesion. And after that, you can see there's a problem getting the wire across. And then we did a balloon dilatation with 2.5 millimeter balloon to get the stent across. And after that, we put a 8 millimeter Cordis precise stent, and then post-dilated the stent with a 5.5 millimeter balloon. And this is the, then we sort of deflated the external carotid balloon. We deflated the common carotid balloon. This is the result which we got. We did some aspiration, and then that's the final result. It's in the internal carotid artery. And we used the same MOMA system, and after that we put a Cristiello ideal stent, which is the stent from Medtronic Invertech, and this has a closed cell design in the middle part where the stenosis is in the internal carotid artery, and it has an open cell design in the common carotid artery portion, and also in the distal internal carotid artery portion. That's the final result which we got. So this case is just to show that we can actually, in cases like this where we have a very tight stenosis, where we cannot get a distal protection device, we can use a proximal protection with ease. Secondly, even in cases of bilateral carotid artery stenosis, if the vertebrals are good, you can actually use a MoMA device. Patient tolerated the procedure quite well, and subsequently on the third day also had a coronary angioplasty to LAD and diagonal, and we have got a follow-up a few months now and is doing very well. So these are the two things I thought was important in this case.
That was a very nice case. How frequently do you do simultaneous bilaterals in the same setting?
Very infrequently. This is probably the second case I've done like this.
And secondly, did you, when your aspiration on the right, did you get any thrombus or material out of that?
No. Actually, visibly we couldn't see any thrombus, but maybe microscopically we didn't examine it.
Okay, Mr. Chairman, we have totally run out of time for the presentation. We'd like to thank Professor Khanna.